Welcome everyone to this IPM speaker seminar. Today, this is the last one of the series for this half of the year. We've had a great year. We've had some great speakers, and we're going to end on a high note with one of our own, Mylynda Massart. Mylynda Massart is MD and PhD. She's a board-certified family medicine physician at UPMC and assistant professor at the University of Pittsburgh. She completed her PhD at the University of Utah in molecular biology and biochemistry, and her medical degree from Oregon Health Sciences University. She currently serves as the founder and director of the UPMC Primary Care Precision Medicine Center. She's the chair of family medicine at UPMC Magee Women's Hospital, and she's co-director for the Hub Core Integrating Special Populations and Community Partners Core at CTSI. She's also associate director of clinical services at the Institute for Precision Medicine. Mylynda has experience working with diverse populations across the lifespan, and has served in the National Health Service Corps in Idaho, working with rural populations, and currently works with the underserved community in Pittsburgh. Mylynda's research interests are in developing education in genetics and precision medicine for primary care providers and trainees, and to be a research catalyst, facilitating the inclusion of underrepresented populations in biomedical research. She teaches residents and medical students in a clinic and at the hospital, and serves as medical director for Bethany Hospice. And I can tell you she's a great teacher because I teach sometimes alongside Mylynda to medical students, and she's really one of the best at getting across the mantra that we have about precision medicine and genomics, and the next wave of how we're going to be delivering medicine, and then the teaching that's required to enable that. Currently, Mylynda is one of the co-investigators for the All of Us Pennsylvania Research Project, working on community education and engagement. In addition, she's working as co-investigator to create the local Pitt plus Me Discovery Biobank at the University of Pittsburgh and CTSI, and developing systems to return precision medicine results to providers and patients. And I think this will be a great sum up. For the first half of the year, we had 4 speakers talk about precision medicine, genomics, kind of next generation medicine. And Mylynda's really, I think, going to wrap that up into how do we actually take all of that great knowledge and then deliver it to our patients, and the experience that she's had here at Pitt and UPMC. Mylynda, thanks for giving the talk.
Thank you so much for the introduction, Adrian. And I'm very excited to be here with everyone today and be the last speaker of the series this year. So for those of you who I don't know, I'm Mylynda Massart, and I am in the Department of Family Medicine. And I'm here to share with you today advances in the clinical implementation of precision medicine beyond oncology, and tell you the story of the Primary Care Precision Medicine Center here at UPMC. So just a quick introduction to precision medicine. I think probably most of you are fairly familiar, but precision medicine is really an emerging approach for disease treatment and prevention, taking into account individual variability, specifically looking at our unique genetics, our environmental and lifestyle exposures for each individual patient. This approach really allows clinicians to predict more accurately which treatment and prevention strategies are appropriate for each unique patient. This is in contrast to one-size-fits-all medicine, which is how we sort of been practicing with evidence-based medicine over the last 50 years, in which disease treatments were designed for the average person, and there was less consideration of the unique differences between individuals. And I think we have come to a stage in medicine where we recognize that we can do better than that, and actually develop more individualized care. So oncology has really been a leading example in implementation of precision medicine over the last decade. We all know that traditionally in oncology, we were treating cancer with radiation, chemotherapy, surgery, and this has now really evolved to look at individual genetics, really customize treatment with immunotherapy, and develop targeted drugs that are specific and appropriate for each unique individual and each unique cancer. And in fact, many of that work is actually happening right here at UPMC in our own cancer research centers, which is incredible, and exciting opportunities for our patients every single day to participate in both the research and also the clinical implementation of these advances. But today we're going to focus beyond the world of oncology and how precision medicine is really impacting overall disease prevention, tailored disease treatment, expanded access to genetic testing, large-scale deployment of pharmacogenomics, how machine learning and AI analytics are going to be critical to advance this, what type of integrated clinical decision support we might need in the future, the integration of additional omics to healthcare, and really even telehealth as a precision healthcare delivery. However, there are still a lot of barriers that exist to implementing precision medicine fully in clinical care. And some of these barriers are outlined here, specifically with testing, availability, cost of testing, reimbursement for testing, as well as turnaround time for results is still a bit of a challenge. On the clinical side, there are very few existing algorithms and lack of real-world data on outcomes and value. There's also very significant lack of patient access to services, which we're going to spend quite a bit of time talking about during this hour. On the information technology side, there's need for ongoing design for data management and how to warehouse all of this information and make it accessible. There's inadequate decision support for point of care tools for clinicians to make these decisions. On the research side, we are still struggling with complicated consenting and data sharing processes. We need to expand our biobanking for ongoing genotype-phenotype discovery, and we need systematic capture of results back to the electronic health record. On the education side, we have a huge barrier with lack of adequate training of our current and future healthcare professionals in genomics and precision medicine. And last but definitely not least, we need to consider all of the ethical issues and consider advancing GINA for privacy and protection of our patients' genomic data. I think many of us recognize that here at UPMC and Pitt, we have an environment which is uniquely set up to actually explore and solve some of these challenges. If we can work together, we can really successfully achieve implementation by integrating all of the things that we have available to us here, from patients to our clinicians, researchers, laboratories, our massive biobanks, our incredible informatics, our electronic health record team, and our overall unified health system balanced with payee and outcomes data. We also are really fortunate to have the Institute of Precision Medicine that is supporting all of the work going into overcoming these barriers and to expanding overall research and implementation of precision medicine. Specifically today, I'm going to discuss a little bit about the advancement of our education opportunities and more specifically around the clinical implementation with our precision medicine clinic. So one of the biggest challenges that we are really facing right now on the clinical side is access. So the need for genomic services is increasing faster than we can possibly train genetics providers. And this is leading to a real backlog of being able to be seen in a timely manner. If we really think about all of the genomic services across the landscape analysis at UPMC, there's quite a diverse array of services that need to be met and provided, including genetic services related to primary care, which we're going to discuss more today, services related to specialty evaluation, genetic counseling embedded in specialty clinics, genetic evaluation and management of various syndromes in the NICU, pediatrics, and adult space, the multidisciplinary need for managing rare disease, the intersection of clinical and research and implementation on implementation projects and industry partnerships, and the future return of ongoing research results. Historically, when we took all the different services that needed to be met and we were filtering them down to one department, this led to a significant bottleneck with a logjam and great amount of time and wait times for patients to get appointments. In addition, it led often to our most specialized clinicians seeing cases that were not necessarily requiring that level of care and expertise. As we move forward, we can really start to reconceptualize genetics as not only a subspecialty, but also now as a tool, and really reference historically other types of subspecialties where this has occurred. As examples are radiology as a subspecialty versus radiology as a diagnostic tool, and cardiology as a subspecialty versus cardiology as a diagnostic tool, which now most clinicians are able to access and order on their own. As genomics becomes more and more affordable and more accessible, this will be really able to expand as integrated as an additional diagnostic tool across the healthcare system. If we think about it in this new model, we can really kind of flip the old model on its head and instead develop a triage model where we get patients to the right level of care that they need with respect to their clinical issues at hand. The benefits of this type of triage genomic services across our healthcare system are wide. In the patient category, there's really benefit around access and time to appointment. Triaging allows them to see the right level of care for their actual need. This is much more cost effective at delivering services and provides patients access to cutting edge precision medicine. On the system side, we would see increased patient satisfaction. We would really serve as a regional center of genomic services and become a national clinical implementation leader in precision medicine. It would be able to balance, maximize reimbursement and downstream revenue generation, and hopefully generate further industry partnerships and increase our research grant funding. So in particular, I am going to talk a little bit today about genetics in family medicine and primary care as a method of triage and increasing access to genomic services. So why does family medicine in particular make sense? It makes sense for many reasons, but particularly because of the diverse array of care that family medicine provides. We are delivering preventative care, which would really allow us to integrate genetic risk testing panels. We do a significant amount of prescription management, which allows us to integrate pharmacogenomics. We are doing routine cancer screening, which could be enhanced with the addition of genetic cancer risk assessment. We are doing prenatal care and newborn care, which again can integrate prenatal carrier risk and IPT and newborn screening. And of course, the ultimate goal to best manage chronic disease. And in the future, this would really include integrating polygenic risk scores and understanding environmental influences. In addition, in family medicine, we really care for patients across the lifespan, as well as multi-generational families, and we have strong relationships and understanding of the biopsychosocial situation of the patients that we care for, all of which are very relevant to applying genetics into clinical care. So some of the barriers to the integration of genomics in primary care are very similar to the system-wide barriers that I introduced earlier, including lack of knowledge and comfort in genomics, again, lack of integrated electronic health record, clinical decision support at point of care, lack of algorithms in terms of delivering precision medicine. Testing itself is highly nuanced. Insurance coverage is not transparent and is very complex. And the technology is advancing rapidly. And ultimately, the most critical challenge of all is time. So ultimately, I think one of the questions that comes up over and over when I discuss integrating genomics into the primary care setting is the time or ability to do quality pre and post-test counseling, as well as the time to really learn and understand the nuanced aspects of testing. Both the type of test selection, insurance coverage, interpretation of results is complex and challenging. In the future, maybe this will get a little bit more simple as we move more and more towards just doing whole genome sequencing and not having multiple options. But while that testing ordering might become less nuanced, the interpretation of the results will become more nuanced and challenging. So what are some possible solutions for successfully integrating genetics in primary care? I'm going to propose 3 models that I have developed over the years, as well as one system-wide model that we could consider going forward. With respect to integrating genetics into family medicine, I have what I first proposed, which I call the classical model, just because it's the one that I originally thought about, which is where family medicine physicians are really trained in a broad scope of practice. And most family medicine physicians are really comfortable managing about 70% of all areas of medicine, right? So rheumatology, endocrinology, cardiology, pulmonology, you name it. The one area that they have not received significant training in yet is genomics. The other thing is family medicine is very, very good at recognizing their boundaries and when to refer to specialty care. So the question is, can we get family medicine providers up to that same 70% confidence in genomics? And how do we educate current trainees to achieve that goal, as well as support current practicing physicians to achieve this goal? The strengths to this model is, as I mentioned before, that many genetic issues align well with primary care topics, including prenatal carrier risk, genetic cancer risk and screening, pharmacogenomic impact on prescribing, and complex chronic disease like diabetes and cardiovascular disease. We also can integrate genetics like all other subspecialty care historically in family medicine. The weakness of this model, however, is that current medical education lacks adequate genomics training. Residencies in family medicine do not have access to strong genomics curriculums. And most importantly, practicing physicians are overwhelmed and cannot possibly conceive of adding expertise on one more topic. And while I have traveled around over the last decade to discuss the idea of integrating genetics into family medicine and primary care, most primary care doctors still think of genetics as being 5 years down the road and not something that's already happening here and now. The second model that I am proposing today is something we call the hub and spoke model of genetic experts serving primary care. This would be to establish primary care genomics experts strategically to serve multiple primary care clinics or a region of primary care providers. And this is actually our current model at UPMC, which we will get more into details later. So again, this would be to embed a primary care genomics expert amongst multiple primary care providers or multiple primary care clinics where they could refer these particular questions to that central hub for any kind of clinical genetics needs. The strength of this particular model is it would require less total number of genomics and primary care experts. It provides a stopgap while education catches up if we can achieve that 70% comfort level for all primary care providers. And it's a great opportunity to teach referring providers with each and every consult that they send to that central expert. The weakness of this particular model is it's really an external visit for the patient. It could also lead to a possible delay in access or service. It's truly an unknown provider outside of the traditional medical home and feels much more like a specialty consult as opposed to embedded in actual primary care. The third model that I would propose is actually one that I'm very excited about, which is the concept of a distributive model of seeding genetic counselors across the primary care space. This would be where a single genetic counselor would serve multiple primary care providers in a multidisciplinary clinic. The strength of this particular model is it is much easier to rapidly scale genetic counselors as it is only a 2-year program. This would allow offloading any nuanced pre-test, post-test counseling and test selection from the physicians. We already have existing multidisciplinary models in primary care with pharmacists, social workers, and nutritionists. And it's a great opportunity for real-time genomics education to occur between the providers and the embedded genetic counselors. The weakness of this model is that genetic counselors are not yet able to bill independently to support their practice, nor order testing independently. There actually is legislation that has been put forth to allow this to happen, and this will be critical for this type of model to be successful. Lastly, I would like to propose more of a system-wide solution, which would be to create a genetic testing utilization clinic model in partnership with our University Genome Center as genomic testing expands. The risk of not having something like this would be sort of like engaging in genetic testing ordering of the wild, wild west, which could include many different risks, such as improper test choice, poor pre and post-test counseling, bad utilization management, inaccurate test interpretation, and in my opinion, one of the worst things, which would be providers discouraged from ordering testing due to sort of an intimidation factor of all of these challenges. By creating this test utilization clinic, we could offer utilization management, pre and post-test counseling, and best test selection. This could be run through a reimbursable genetic counselor facilitated testing clinic as an interface between the ordering clinicians and the genomics laboratory, and really support all clinicians and patients going forward to get the best test ordered, best reimbursement, informed consent, and proper interpretation, and really increase access to genetic testing as a tool in a facilitated manner. So I'd like to switch gears and tell you a little bit more about our UPMC Primary Care Precision Medicine Clinic, which was launched in late 2019 within the Department of Family Medicine. This is our clinic team here. On this slide, we really launched this clinic to meet the current needs of patients who were seeking precision medicine level care. We also really wanted to explore more the idea of primary care genetics and determine best practices and algorithms for the integration and advancement of genetics in primary care, while serving to advance best practices for the clinical delivery of precision medicine in general across the health system at UPMC, and expanding ongoing genomics education, particularly for learners and primary care providers. So the clinic was started by myself and Dr. Phil Empey from the School of Pharmacy. And we have two incredible genetic counselors, Natasha Berman and Christine Monroe, as well as our clinical pharmacogenomics led by Dr. Luke Berenbrock, and our current fellow who is just getting ready to graduate, Dr. Katie Ryden. When we built the clinic, we envisioned the clinic serving the needs of many different types of possible patients. Some of those patients were early adopters who we already knew were out there looking for this level of service and weren't able to access it. We wanted to have a space that could support return of research results from all of us, as well as in the future from Pitt plus Me discovery. We also wanted to be able to further explore the implementation of clinical pharmacogenomics. And as I mentioned before, to serve as a triaging system to filter patients to upstream genetic specialists who need that level of care. In addition, we wanted to be able to provide consultation to individuals undergoing direct consumer genetic testing, serve as a primary care medical home for individuals and families who already know that they have a specific genetic condition, and serve as a consultative service for primary care providers and specialists who needed guidelines and support in terms of test selection, ordering, and interpretation. The clinic works in a multidisciplinary workflow. Our genetic counselors see each of our patients for an initial intake and complete a family and individual health history and pedigree, and undergo risk assessment with the patients. Our pharmacogenomics team, when relevant, meet with the patients and complete a medication review, testing recommendations if appropriate, and personalized result care integration upon return of results. And then the physician reviews the history that's been obtained, completes the exam, and is responsible for overall care planning. We meet as a team weekly in a multidisciplinary case review to make final recommendations for each patient and complete pre-test counseling and when testing is recommended, as well as return of result visits with consult notes back to the referring provider. And we are very excited to share this model as a novel delivery system this winter in the Annals of Family Medicine. In addition, just like everyone else in early 2020, we had to rapidly convert to virtual model for our clinic and launch into the world of telehealth. It turns out that telemedicine has been an excellent venue for us to explore and is a successful model both for our team, the type of services we deliver, and our patients. and has allowed us to increase our service area to rural areas, as well as our expanding UPMC footprint. In addition, in the last year, we launched e-consults, which allows providers to send referrals for quick review and triage through Epic, again, to try to get patients to the best level of care as quickly as possible. So since we started, I know this is a busy slide, but I kind of wanted to give you a flavor of some of the types of testing that we have done with our patients. We have seen a large cohort of connective tissue disorder patients, which I'm going to tell you a little bit more about in a few minutes. We have done some extensive genetic cancer risk assessment in the primary care space, numerous pharmacogenomics consults, as well as direct-to-consumer education and validation, carrier risk testing, and then what we call adult genetic testing utilization clinic, which is referrals from other subspecialists. We have also launched a partnership with the University Genome Center here at UPMC and Pitt to explore how to expand clinical whole exome and whole genome sequencing within UPMC. And if you can see in the bottom left-hand corner, in the blue is just showing our volume in last year compared month to month to our volume this year. And you can see how rapidly the clinic growth has developed year over year. We currently only see patients 1.5 days per week, and already that is becoming access limiting, and we are continuing to think about how we can expand our services. So one of the largest referring subspecialties thus far has actually been a great collaboration with our neurologists, both here at UPMC and at Allegheny Health Network, as neurogenetics has truly expanded over the last several years. And you can see here just some of the types of neurogenetic cases that we have had an opportunity to evaluate. And in the very near future, we are hoping to test the distributive model that I shared with you earlier by embedding one of our genetic counselors into the Matilda Tice Health Center to really ensure that we are delivering accessible care to our underserved patient population here in Pittsburgh, and to reduce barriers of transportation, digital divide, and improve trustworthiness around genetic services. So now I would like to share with you a little bit about some of the projects and patient stories that we have engaged in over the last couple of years. Some of these will be more primary care focused, and some of these will be more precision medicine system-wide focused. So one of the first projects that we really wanted to embark upon was the evaluation of connective tissue disorders and hypermobility spectrum disorder within the aspect of primary care and genetics. It really turned out that this was a large unmet need here in our health system. And patients were really struggling to find evaluation and supportive care for the conditions that they were experiencing in this spectrum. So we have started a project where we are evaluating these patients, really exploring their soft comorbid findings, their intermediate comorbid findings, and their hard findings, really trying to understand where they fall on the spectrum of hypermobility from asymptomatic to highly symptomatic with multiple comorbidities, what the exclusion process looks like to evaluate for autoimmune disease, other inflammatory diseases versus connective tissue disorders, and who exactly would then meet criteria and what are the criteria for genetic testing. So again, ultimately, this is to develop an algorithm for primary care to manage connective tissue disease within that space, be able to guide who needs genetic testing, what type of testing is appropriate and why, and also, more importantly, how we can optimize symptom management and further refine the clinical criteria, particularly for hypermobile EDS. We have really looked at advancing comprehensive management for these patients, what that could look like, again, with multidisciplinary supportive care for each of their comorbidities versus actual high-risk screening for those who meet those higher criteria, and monitoring for any of the more severe outcomes that could potentially happen in their lifetime. So far, we have evaluated over 90 patients, and we just recently were joined by a master's thesis student who is taking on this project. A second project that we have been working on this last year is multi-cancer early detection using liquid biopsy. For those of you who are not familiar, liquid biopsy is looking at sampling and analysis of non-solid biologic tissue, so primarily blood. This can be used for diagnostic and monitoring of diseases. And the benefit is that it is mostly non-invasive other than the blood draw and can be done serially over time. There are several types of liquid biopsies that currently exist out there on the market, including cancer, looking at circulating tumor cells or circulating tumor-free DNA or ctDNA. In the field of cardiology, there are circulating endothelial cells that are now being sampled and evaluated. And in prenatal diagnosis, cell-free fetal DNA is being extracted from maternal blood to analyze for various aneuploidies. So again, the first real clinical example of this was non-invasive prenatal screening, which was approved by the FDA in 2014, looking at free fetal DNA that is circulating in maternal serum by about 8 weeks of pregnancy. Currently, it is only approved for aneuploidy analysis, but in the future, you can imagine once we have access to that fetal DNA, we won't be limited in what type of studies we could do for evaluation and diagnosis in the prenatal space. So I think there will be much more to come. In the cancer side, liquid biopsies are used from anywhere for cancer detection and screening early in diagnosis, molecular profiling of actual tumor cells, detection of residual disease after treatment, and monitoring treatment responses. In the primary care space, we're excited to actually introduce this as sort of cutting edge cancer screening. I think all of us have been frustrated over the years at the limited amount of cancer screening that we have had available to us, which has only included mammograms for breast cancer, Pap and HPV testing for cervical cancer, colonoscopy and Cologuard for colorectal cancer, low-dose CT scans for lung cancer, and the PSA story for prostate cancer. Not only have many of these not been highly successful in terms of screening, they frequently have a high false positive rate. They are each unique for each cancer, so each time you're getting a separate test, and several of these are considered to be highly invasive. With the introduction of multi-cancer early detection, this is now just a single blood draw that actually looks for 50 cancers. It's extremely exciting because the rates of detection at stage 1 and 2 are actually quite good for specifically cancers that we've had no screening for in the past, such as ovarian cancer and pancreatic cancer. This technology that has been released through the test called Gallery is actually looking at methylation patterns of cell-free DNA that are specific and indicative of cancers, and also looking at methylation patterns that indicate the tissue of origin of the cancer. So when the results come back, not only do you know if someone has a suspicion of having cell-free DNA with a cancer signal, but you also are directed immediately to what type of tissue of origin to look for in the diagnostic evaluation. So another area in the primary care space that we've been working on is how to support patients undergoing direct-to-consumer testing. As of October 2020, about 1 in 5 Americans have actually taken a direct-to-consumer genetic test. And where do they go in our health system with this information when they have questions or possibly a result that could be clinically relevant? So we are seeing many of these cases, and the majority of the time it's really just to provide education around their results and trying to understand what they were seeking in terms of looking at direct-to-consumer testing. But we have had a couple of cases that have been fairly significant that we have gone on to do validation. And this is just one of those. This was a gentleman who underwent a direct-to-consumer genetic ancestry test. And he took that data, the raw data from the ancestry testing, and ran it through a third-party interpretation site on the internet to look for potential risk for various health conditions. And this third-party site returned back that he had a pathogenic variant in a MEN1 gene, a pathogenic variant in the STK11 gene, a pathogenic variant in COL5A1, and then 2 carrier risk genes. When he came to see us, as I mentioned before, we always start with a detailed personal and family history to generate a pedigree. We realized that the patient himself had had 2 previous pneumothorax, which could be consistent with a connective tissue disorder. His sister had ovarian and colon growth. He had a mother with a history of thyroid cancer and a paternal grandfather with a colon tumor. The patient had already had his children and they were healthy, so he really wasn't very concerned about the carrier risk variants, but he was very concerned about the cancer and the connective tissue disorder genes. So we created a custom panel for him and went ahead and did that validation. And it turned out that all 3 of those results were incorrect, and he did not have any pathogenic variants in any of these 3 genes. So ultimately, the moral of this story is that while direct-to-consumer reports are very interesting and likely to be accurate, any third-party interpretation of raw data is very much likely to be garbage. Again, in the primary care space, we have had probably over 100 consults at this point in the pharmacogenomic space, and just wanted to share 2 of these cases with you today. The first one is a 19-year-old female who had very poorly controlled postoperative pain after a spinal surgery. She did not respond well to any of the medications that had been trialed postoperatively and was going to be scheduled for a second procedure. She actually had some PTSD around the postoperative pain management and was very nervous about the next procedure. And so her surgeon and anesthesiologist reached out to us for a consult. It turned out the patient did have a CYP2D6 intermediate metabolizing gene variant, which can impact her ability to metabolize various different pain medications, particularly pain medications that one might think of using as first choice in a young adult. And so we were able to guide her surgeon and the anesthesiologist in some optimal choices for pain management. And that second surgery went much more improved. And she was very empowered going into that surgery with this data. 6 months later, we were actually reconsulted on the same patient, this time from her psychiatrist regarding treatment-resistant depression. And we were able to immediately refer back to the testing results that we had obtained already and make those recommendations. A second example of how we've used pharmacogenomics so far in the clinic is a patient of ours who's a 51-year-old female who had a stroke in 2009 and was now having recurrent peripheral vascular and peripheral arterial disease. She's an ongoing smoker and was on Plavix and aspirin for management. However, she was failing treatment and continued to have recurrent occlusive disease with admission multiple times to the hospital. And we started to wonder whether this was a medication failure versus ongoing environmental risks with her persistent smoking. We started the process to get her pharmacogenomic testing completed, and she was actually admitted to the hospital during that time frame. The inpatient service saw that we were ordering this testing, so they decided to go ahead and switch her from Plavix to ticagrelor to see if that would improve her outcomes. And instead, she ended up actually developing shortness of breath due to her underlying COPD and the risks with that particular medication. In the end, it turned out that her CYP2C19 gene testing, which is what is responsible for converting Plavix from its prodrug to its active state, came back as normal. And so we did know that Plavix was the right medication for her. We were able to switch her back to get rid of the side effects from the ticagrelor and actually really do personalized counseling about her need to quit smoking and how this was most likely the ongoing risk factor. Another case that we have been working on over the last year, more from the precision medicine side of the clinic now, is a case of unexplained recurrent rhabdo. This was a 29-year-old male who was previously healthy, who came in to see us after developing multiple episodes of rhabdo, which led to hospitalization, as well as some less severe episodes at home. No one was able to identify any triggers for why the rhabdo was occurring. All of his lab results were non-revealing, and he was sent to us for genetic evaluation. We sent a panel on him, which identified a mutation in the RYR1 gene, which was likely pathogenic and autosomal dominant and known to be disease-causing for rhabdomyolysis. In addition to variants of uncertain significance were identified as well on that particular panel. The patient came in for counseling regarding this finding and was educated not only about the risk for the rhabdomyolysis, but potential risk as well for malignant hyperthermia with this particular gene variant. And we also followed up with his mother and brother for familial variant testing and counseling, as each of them turned out to also to carry the same RYR1 variant. After several months, the patient recontacted us with his neurologist due to ongoing persistent symptoms. We followed up with him and found out that his mom and brother continued to not have any symptoms at all, while he was actually now having almost daily symptoms with his muscle spasms, cramps, and more severe rhabdo cases, as well as 2 more additional hospitalizations. So this really led us to think that clearly we were not seeing the whole story here, as his mother and brother had the same variant and were asymptomatic. And we partnered with our genome center and proceeded with whole exome sequencing. This testing came back with the original finding of the RYR1 variant, as well as the 1 variant of uncertain significance in the PCPM gene, which was originally found. However, the whole exome sequencing yielded a second intronic variant that was not found on the original panel test. This was very, very suspicious, as this is another significant cause for rhabdomyolysis. Currently, he is undergoing repeat muscle biopsy to see, with now his more persistent and frequent symptoms, if there's any changes in the muscle biopsy, as well as PFK enzymatic testing on that sample. And parental testing is happening currently at the Genome Center to determine whether these variants are in cis or in trans. The next case I want to share with you is a very challenging case and diagnostic odyssey of a 28-year-old male patient who came to see us referred by his neurosurgeon after waxing and waning neurologic symptoms since his late teens. He had had an injury in his late teens and a surgery to correct that injury, and actually recovered from that quite well, to the point where he was playing sports again, but then progressively, increasingly developed symptoms of intermittent upper and lower extremity weakness, to the point that he is now using a power wheelchair. He had had multiple evaluations and consultations where the pattern of his symptoms could not be clearly identified and was often mislabeled as functional. And after the neurosurgeon reviewed and excluded the prior surgery as a cause of his symptoms, was sent to us for genetic testing. His results came back with a novel mutation in the KIF1A gene, which is shown here. This had not been previously reported, and his particular variant leads to a premature stop codon and truncation of the protein. The majority of KIF1A associated disorders are spastic paraplegia, which are autosomal dominant, as well as hereditary neuropathy, which tend to be recessive, and spastic paraplegia. And when we really look back at his symptoms, he sort of had a combination of multiple of these different symptoms, which is why they may not have made clinical sense in the past. His particular mutation, unlike the majority of KIF1A variants causing disease, which are down in the motor domain, is actually up here in the C-terminal domain, and that truncated protein is likely interfering with cargo binding and transport. Since this mutation had never been reported before, we wanted to see if we could launch any functional studies, and we ended up finding a partner lab in Japan that has a C. elegans model that studies the KIF1A gene, and they were able to recreate our patient's specific mutation and show that it cannot bind and transport the vesicles and is functioning as a pathogenic mutation. His family is currently being set up for testing back in England as well. This next case is one that I'm going to speed up on just because of time, but this particular patient came to see us for evaluation for genetic testing for hidradenitis, which is a very challenging condition, and she is getting ready to have children and wanted to make sure she did not pass this on to her child. So we actually did do inflammatory genetic testing on her, which revealed a likely pathogenic variant in the NCSTN gene, which is also autosomal dominant and known to be associated with hidradenitis. Since she was discussing having children in the near future, we also offered expanded carrier risk testing to this couple, in addition to their concern around the hidradenitis gene. And these results just recently came back showing that they are not only both carriers of hemochromatosis, but in fact, the male partner has both copies of this mutation and is affected, but had not yet clinically been diagnosed with this condition. And lastly, this is a patient of ours who was referred from dermatology. He's a 57-year-old male who had developed extensive palmoplantar keratoderma, which can be genetic in its own or a hallmark of malignancy. He was particularly concerned because, as you can see in this pedigree, his brother and both of his parents have had cancer, as well as 2 additional cancers on his mom's family side. And so after counseling with this patient, we proceeded with genetic testing, both to look specifically for palmoplantar keratoderma, as well as hereditary cancer genes. But as I mentioned earlier, since we had just launched the Gallery multi-cancer early detection test, we shared that with this patient who was quite anxious about the possibility that he could have an underlying cancer. And so he was able to complete this test, which was negative, and highly reassuring for him while we're waiting for his other genetic testing results to come back. So where are we going in the near future? We are really hoping to look at preventative population genomics, including panel testing that might look at all hereditary cancer genes, cardiovascular genes, pharmacogenomics, carrier risk, and polygenic risk scores in the near future. This could be done through expanded return of secondary findings beyond ACMG 73 on all of our future testing at the Genome Center, or as a population-based screening panel with a whole genome sequencing background, which could then have data that's stored for subsequent clinical-driven query if indicated. In the long-term future, we are also looking at how do we grow population whole genome sequencing? How do we further integrate into the electronic health record systems? What would big data analytics and additional omics look like in the care of our patients? And again, advancing real-time decision support. We really consider our clinic to be part of our learning health system and are consistently trying to provide education back through our consult notes to our referring primary care providers and specialty providers. And we are very excited to be expanding our Shadyside Family Medicine residency program with a training track in primary care precision medicine, with our first resident starting in clinic this July. We've also been very excited to work with the University Genome Center here at UPMC. You can see that they are a lot of fun, and we are having monthly meetings with them to review our cases. We are able to provide them direct access to the electronic health record to improve communication around phenotyping for West interpretation. This is also really allowing us to have direct communication and advanced science and reinterpretation on complex cases, and overall integrate clinic and lab into one system. Future goals for the primary care precision medicine clinic is really to expand our implementation, expand our access, specifically in equitable services, as I mentioned before, with embedding genetic counseling into some of our primary care clinics directly, and thinking about that primary care preventative population screening. And as I mentioned earlier, we are really investing in education, and Dr. Empey and I are very excited to announce this very near complete course through Test to Learn, which will be specifically on whole genome sequencing to advance clinical care. It's a course that is designed both for clinicians as well as other key opinion leaders who are interested in learning more about whole genome sequencing and its applications. And this will likely be launching within the next year here across campus. Finally, I would like to acknowledge Jonathan Steele and Emily Welsh, who our clinic would not run without, as well as everyone else on this slide who has provided their encouragement, support, and incredible partnerships over the last 2 years. And with that, I'm going to wrap it up and say thank you.
Thank you, Mylynda. That was fantastic. I will clap on behalf of everyone who's on the Zoom call, and several people did their electronic claps as well. So there are a bunch of questions in the chat. I will, for the sake of time, because there's quite a lot, I'll read through them and hopefully we can get through them, and then we can actually open it up and people can ask questions as well if they wish.
That'd be great.
First one, some are softballs and some are not so softballs. First one's an interesting one. What is done for patients who are adopted when a pedigree can't be obtained?
Yeah, so I think that's a great question and actually of great interest to the adoptee community. Many patients who are adopted have turned to direct-to-consumer testing, both to discover their ancestry as well as potentially discover their health history. We've actually seen numerous patients who have engaged in direct-to-consumer testing for that reason and who have learned very interesting things about their health history and are incredibly relevant. So those are great topics for discussion and really a launch point to talk about their overall healthcare and how can we use population-based screening to help them uncover perhaps any risks that they didn't know about before.
Second question. So commercial pharmacogenomic testing focuses a lot on psychiatric medications. Would UPMC pharmacogenomic testing offer advantages in terms of better accuracy and ease of testing for our patients? Is that going to be offered?
Yes, so we are very much hoping to be offering internal pharmacogenomic testing. Many of you know that our Pitt plus Me Discovery Biobank is offering return of pharmacogenomic testing results back to the electronic health record, which we are getting very close to completing. I do think that we will have extremely accurate results. However, of course, our understanding of pharmacogenomics is continuing to evolve. And so therefore, the interpretation of those results is continuing. I think that the difference between some of those commercial tests is that those testing sites often overinterpret the results. And I think the benefit of our current clinical pharmacogenomics experts is that they are not looking at the report interpretations, but rather at the data itself and providing our recommendations based on national CPIC guidelines.
Yeah, and a question from Laurie Stearns. I think this is important. She says, exciting work so far. I love that some of the models will support individuals in lower income communities. Can you speak to the next steps for a patient? What happens next if there is a need for follow-up testing and care? And are there concerns about payments for follow-up?
Yeah, I think these are great questions. And I think the first line is really getting the services to the patients. It turns out that many of these services are covered now through insurance, including Medicaid and Medicare when indicated. And so if the indication is identified in the primary care space, I think that then getting access is something that is surmountable. In addition, many of the testing companies have special rates, sliding scale fees for patients to help accommodate and make them accessible as well. But I think that that's a great question. But the first place I want to start with is even getting the access to these services to our most vulnerable and underserved patients, which currently isn't happening routinely.
And a couple of questions on liquid biopsies. One, how is a liquid biopsy different to a regular biopsy? And secondly, is a liquid biopsy more specific than CEA or CA125 or one of these blood-based biomarkers?
Yes. So the first part of the question is the difference between a regular biopsy is a tissue sample. So depending on where that tissue of origin is, first you'd have to know where you wanted to go and biopsy and sample. And then that is often quite invasive. So for example, sampling the liver or the kidney or the lung is a bit of a challenge, whereas the skin is a little bit more easy. So the liquid biopsy is actually a blood draw. So same as any blood draw when you go to the lab, so significantly less invasive. Additionally, we don't know specifically if there is a cancer or where it would be located. So instead of screening all over the body, which would be, inefficient and impossible with regular biopsies. The liquid biopsy is actually able to look for, like I said, about 50 or more cancers that could come from anywhere in the body for that cancer signal.
And from David Feingold, he said, I'm unaware of technologies to extract fetal cell-free DNA. Would you direct us to this technique?
Oh, yes, I will definitely send you resources to this.
And we are happy to open up if someone, I think people can unmute themselves if anyone wants to verbalize themselves and ask a question.
I just want to say thank you. This was great.
From Leah.
Yes.
Thank you.
I will ask a question. If there's silence, I will ask a question. You talked a lot about scalability, the challenges of scalability with there are clearly not enough genetic counselors for everyone that needs genetic counseling. And in those models at the start, when you talked about these different models of distributed genomics and testing and stuff, and the very first part you touched on was triage, the ability or the importance of triaging to the right test and the right amount of care. I know there are artificial intelligence and computer ways that are trying to develop the counseling part, so chatbots for counseling and that. Have you seen efforts to do that first part, the triage part? Is there artificial intelligence ways or computer ways that it could mine the EHR or mine their pedigree and send them to the right place that would at least take a bit of that roadblock off?
I actually haven't seen that yet, but I think it's a brilliant idea. I think that would leverage the type of AI that we are seeing in the electronic health record space and would be a great use for that in terms of looking at chief complaints, looking at family histories, looking at medication usage and all the data that's already integrated. And I guess we could call that precision triaging.
Yes, good point, good point. There is, oh, one more message was great talk. That's good. From iPhone 2 said great talk. If there are any more questions, people are welcome to speak up. If not, Mylynda, that was fantastic. That was, as you said, a great end to the seminar series for this half of the year. I think that really summed up the challenges and the opportunities in delivery of precision medicine care. And we thank you all again. Thanks.